So the September MEC Minute is going to be about vascular emergencies. And these are the things that you need to think about, be aware of, and you really don't want to miss. Although one or two of the items I'm going to discuss may not be immediately obvious to you or may not always be at the top of your list. I think you should always be suspicious of these conditions when you see patients with certain symptoms, and we'll talk about that. So what symptoms are we, or what diseases are we going to talk about today? We're going to talk about carotid dissections. This is one that is not very common. I can tell you and admit that I've not missed one or two, but I've had a couple cases where I really didn't think the patient had it, didn't really cross my mind, but imaging later showed that carotid dissection was present. So we'll talk about carotid dissection. We'll talk about aortic dissection, which is predominantly a injury to the aorta that occurs within the chest. We'll talk about abdominal aortic aneurysm, probably the thing that you are most comfortable with and most familiar with, and acute ischemic gut or acute mesenteric ischemia. And then finally, we'll talk about acute arterial occlusion. And when I say that, I'm talking about peripheral occlusion involving the extremities, which is usually the leg or a leg. Starting with carotid dissection, well, what is it? Well, it's a tear in the inner layer of the carotid artery. It can be due to blunt trauma to the neck or penetrating to the trauma to the neck, or it can occur spontaneously. Really, we see it more commonly with blunt trauma simply because of the trauma that we see at East. So patients who have hanging injuries or any type of strangulation injury, any injury to the neck from blunt trauma, could be a seat belt across the neck. You have to think about carotid dissection. You also have to think about it with penetrating trauma to the neck when the trauma is near the carotid sheath. And sometimes it can occur spontaneously, and those are the ones that sometimes fool me. Those are the ones where I know it's on the list of differential items that could be causing the patient symptoms, but it's not high on my list. So what are the risk factors? Well, there is blunt trauma, penetrating trauma. Those are pretty obvious. But other risk factors include Marfan's disease, which is a connective tissue disease, and other connective tissue diseases that are out there. And if you think about carotid dissections, so look at their prevalence, they account for about 2.5% of the strokes. So if you have a dissection of the carotid artery, there may not be adequate blood supply to the brain, and this could give you stroke-like symptoms in the area of the brain that is supplied by blood from the carotid artery. So how do we look at this? What are the symptoms that we look at? These patients could have symptoms related to trauma, so those are pretty specific, but particularly in those patients who have atraumatic carotid dissection, patients may have headache on the side of the dissection. They can have facial pain on the side of the dissection. So if the patient is complaining of acute facial pain with no previous history, think about, could this be a carotid dissection? They could have neck pain, they could have eye pain, they could have visual changes to the affected eye, they could have symptoms of stroke, and they could have Horner's syndrome. So what is Horner's syndrome? Well, Horner's syndrome is a constellation of symptoms that are related to injury to the sympathetic nerves that are near the carotid that's affected. So by typical definition, Horner's syndrome, and we have a picture of a guy on the left with Horner's. Horner's has a constricted pupil on the affected side. They may have a droopy eyelid on the affected side, and they may have decreased sweating on the affected side. I'm really not good at finding decreased sweating on the affected side simply because when patients in the emergency department, they tend not to sweat. They're not sweating. You can also notice on the patients with Horner's syndrome that the eyeball seems to be recessed or pulled back into the socket. So if you look at this picture, the patient's left or your right, the left eye, the pupil is smaller. He does have a little bit of droop of the lid on the left side when compared to the right side. I can't tell you whether or not he's sweating, so I'm going to take a pass on that. But he also, if you look at it, you have this perception that the eyeball is shrunken back into the socket a little bit. So this is a patient with Horner's syndrome. It's something that you should think about and look for. This is something that you can evaluate for patients or use to evaluate patients who are complaining of unilateral headache, facial pain, eye pain, neck pain. You think about looking for a Horner's syndrome because that just increases your level of suspicion. So what's the complication of carotid dissection? Well, the biggest complication we worry about is risk for stroke. Patients sometimes can proceed to have intracranial bleeding, but stroke is the big one. So how do we diagnose this? Well, first we have to start out with suspicion. We have to think that something is going on. Typically we'll get either a CT angiogram of the neck or MR angiogram of the neck. If we get the neck, we tend to get the brain as well. The CTA is easier for us to get in the emergency department and faster to get than an MRI. So if the patient comes in with acute neck trauma, whether it's a strangulation injury, a hanging injury, blunt trauma from a seatbelt, or penetrating trauma, we can take the patient directly to CT angiogram, which is done in the CT suite. It's the same type of imaging we do on stroke patients, and we can get the procedure done. If we're worried about the patient having an atraumatic cause of dissection, we can do the CTA for the same reason. Well, how are these patients treated? Well, if the tear is big enough and bad enough, interventional radiology or vascular surgery will take the patient and place a stent. Most of the patients I've had experience with, however, are treated with anticoagulants or antiplatelet medications, and the decision of which route you're going to take is really made by the vascular surgeon. So we get the specialist involved early. They'll look at the images and make a determination of what needs to be done for that particular problem. So here are some images. If you look at the images, if you look at the image on the left, this is a CT looking at the base of the brain. When you look at CTs, we look at the images from the perspective of we're standing at the foot or feet of the patient looking up toward the head. So what is on your right is the patient's left. So if you look at this on the left-hand side, you can see the red arrow. That's a normal carotid artery. It's fairly round. It's well lit up. It's lit up because there's intravenous contrast in the artery. Whereas if you look on the left-hand side, you can see a little flash of white, which is contrast. The rest is narrowing of the lumen because of a hematoma in the carotid wall from the dissection. If you look on the right-hand side, this is a CT angiogram of the neck with cutting the patient down kind of front to back. This is called a sagittal view, and you can see the yellow arrow. That is actually the tear that's in the carotid artery, and if you look above it, you can see some loss of the diameter of the carotid lumen as identified by the red arrow. So that's what a carotid dissection looks like, and this is a good example of how we look for it. The next is going to be an aortic dissection. An aortic dissection is a tear that occurs in the inner layer or between the inner layer and the middle layer of the aorta. There's a tear that develops, and then blood, because of that water hammer effect of the pulses, will dissect between the layers of the aortic wall, causing a defect. The tear could be due to trauma, particularly blunt trauma to the chest. So patients who have a sudden deceleration injury to the chest, usually from like an auto accident, can develop an acute dissection, or these dissections can occur spontaneously. So outside of trauma, what other risk factors are there for aortic dissection? Hypertension is the big one. Marfan's disease and other connective tissue diseases are risk factors. Tobacco use is a risk factor, as is cocaine. Having a bicuspid aortic valve, meaning an aortic valve with two valvelets to it, not the typical three. Bicuspid valve is a risk factor for aortic dissection. And then an aortic aneurysm within the chest can also result in an aortic dissection. So the aortic aneurysm can develop with time. There's gradual widening of the caliber of the aorta, and then for some reason at a certain point in time the patient develops a tear in the aorta, and then there's acute dissection. Typically this occurs when the chronic aortic aneurysm gets to a certain size. So the smaller aortic aneurysms tend not to dissect emergently or acutely, but it still can happen. It's more common with the bigger aneurysms. So what are the symptoms? Well, the symptoms that we always think about are this acute onset of tearing, stabbing, pain. It can be in the front of the chest, or it can be in the back of the chest, between the scapula, between the shoulder blades of the back. So it's typically this, if you want to read the textbook, this acute searing, tearing pain of the upper back. Patients could have symptoms of an MI or STEMI, particularly if you look at electrocardiogram. So when you think about an aortic dissection, some of the symptoms could be related to the blood vessels that may get clipped or cut off as this dissection progresses. So if you have a dissection that starts near the heart it's possible those tears can clip off or cut off blood supply to the coronary arteries, and the patient may have chest pain, and you do an EKG, and they've got a STEMI because the coronary artery is not receiving adequate blood supply. And we'll see that not frequently, but we do see this in STEMI patients. They come in, they look like a STEMI, they sound like a STEMI, the EKG looks like a STEMI. They go to the cath lab and they have a STEMI because they've had an acute aortic dissection, and the treatment is to manage the dissection. Other symptoms these patients may have could be syncope. Patients could have stroke symptoms, so if the dissection starts close enough to the heart and then dissects peripherally, it can clip off one or both of the carotids. If you cut off the carotid, you then get stroke symptoms because there's inadequate perfusion to the brain. If you have a dissection that starts beyond the carotids, beyond the subclavians, so it's going down the lower part of the aorta, you could actually get other symptoms. And I've had patients who've had a distal or dissection. They cut off the blood supply to the GI tract, and the patients develop acute abdominal pain and acute bloody diarrhea, and it can be really difficult to manage. So what's the complications of this? The biggest complication of these things is death, because if it's not properly identified and treated, or even if it is, if the dissection is bad enough, the patient may have conditions that cannot be fixed. So if the patient has an acute STEMI because of this, they may have a cardiac death. If the patient has a dissection that's bad enough to cause a stroke, they could die from the stroke. Or if the dissection involves the kidneys, blood supply, or the blood supply to the abdominal organs, the patient could die from that. So how do we determine what they have? Well, you have to have this high level of suspicion, and you really have to have it for all the conditions I'm going to talk about. The patient may have a blood pressure difference between the right arm and the left arm. The right arm might be normal, the left arm may be low. So think about getting blood pressure in both arms. The patient may have cool or cold limbs, so examine the body parts. Is one arm warm, one arm cold, or the arms warm and the legs cold? And then in the emergency department, we'll do imaging, which includes maybe a chest x-ray, maybe an echocardiogram, which is an ultrasound of the heart. But if we really have a high level of suspicion for aortic dissection, we're going to go directly to a CT angiogram or an MR angiogram. Again, the CTAs are much easier to get accomplished quickly than the MRAs. We can get them 24/7, but it just takes time to get the patient into the tube and to do the procedure. We can get the patient on a CT table quickly, and the CTA itself takes a minute, 2 minutes at the most. So it's much faster, and we get good quality images both ways. Here's just kind of a map of what the dissections look like. There are really two classifications, the DeBakey and the Stanford. Most of us use the Stanford definition, type A and type B. So a type A starts at the proximal aorta and then can either go all the way down to the groin or anywhere in between, whereas the Stanford type B starts at the descending aorta. It starts distal to the left subclavian, and it then goes from that area downward toward the abdomen and the groin. So how do we treat these? Well, in the emergency department, it doesn't matter if it's an A or a B. We immediately manage the blood pressure and pulse, because if the patient is hypertensive and tachycardic, we want to reduce the blood pressure and reduce the pulse rate so there's less of this pulsating pressure up against the aorta, which could then cause the dissection to progress and worsen. For those type A's, those that are the dissections that come up out of the proximal aorta and go up through the loop, those patients tend to be treated surgically, so thoracic surgery will take them to the OR. Type B aneurysms tend to be more likely managed medically with antihypertensives. Sometimes they go to surgery depending on the severity of their symptoms and how well they respond to medical management. And then we have to treat their complications. Here's some imaging. This is a single patient. This was a patient, I believe, brought in by one of the Columbus medics. They were really on it. They had a suspicion that something wasn't right with this patient. Acute onset of pain and loss of pulses in his lower extremities. And you can see with the red arrows that dark line is the lumen, or is the dividing wall between the normal aorta and the dissection. So this is a good graphic representation of what this looks like on imaging. This is a great set of films that I've been keeping around for the past year or two. Abdominal aortic aneurysm, this is one that we commonly think about. What is it? It's a progressive enlargement of the abdominal aorta. It is not a dissection. It's a weakening of the wall of the aorta, so that you get this ballooning effect. It's just like what you might see on a garden hose that develops a weakness. 85% of the abdominal aortic aneurysms are below the renal arteries. That's kind of a good thing because the renal arteries make it a little bit more difficult to manage surgically. But the other 15% are at or above the renal arteries and then go distal to that. Risk factors, family history is important, smoking is important, hypertension, hyperlipidemia, and atherosclerosis, or hardening of the arteries, are risk factors. Atherosclerosis is probably the #1 risk factor, with smoking and hypertension coming after that. Family history we have to be aware of. The only thing we can do about a family history of aneurysm is make sure we reduce our other risk factors, which include smoking, hypertension, and hyperlipidemia. What are the signs and symptoms? Often the abdominal aortic aneurysms are asymptomatic. We find most of them on imaging as part of imaging we do for other reasons, like somebody comes in for abdominal pain, a patient comes in for possible kidney stone, whatever. So we'll find aneurysms then. They tend to be small to medium size. We don't do anything about them initially, but refer them off to vascular surgery. But most are asymptomatic until they rupture. Once they rupture, the patients can have back pain, chest pain, or abdominal pain. Sometimes they can have abdominal discomfort, or maybe not even have abdominal discomfort, but you examine the abdomen and you feel a pulsatile mass. If you feel a pulsatile mass, generally it's a pretty good sized aneurysm. Sometimes when we have our skinny folks, we can palpate the abdomen and we'll feel a pulsation. We may think they have an aneurysm when we CT them. They don't have an aneurysm, they're just skinny and they don't have a lot of tissue in between my hands and their aorta. Sometimes patients can have a syncopal episode because they have an aneurysm that's been asymptomatic, and then it pops and they pass out because of lack of blood flow to the brain. Biggest complication to aneurysms is death, particularly on rupture. If they survive the event, they may have other complications like acute kidney injury. They could have gut ischemia resulting in need for surgery, and so on. How do we diagnose these? Well, again, suspicion has to be one of our big things. I'm really impressed with how EMS providers will come in and say, I think this guy might have an abdominal aneurysm. He's having abdominal pain and back pain. Often they're right, particularly if the patient's hypotensive. We have to do a good exam, and then we can move on and do imaging. So how do we image? We can do an ultrasound. We can do a non-contrast CT, or we can do a contrast CT with CT angiogram. In patients who are acutely hypotensive with symptoms suggesting aneurysm, we go right to a quick ultrasound at the bedside. The device is portable. It takes a couple seconds to turn on. If we see an aneurysm, we're done. We could start resuscitating the patient. We could call vascular surgery, and they manage the patient. We don't necessarily need to wait for a CTA on an unstable patient. So here's some imaging. On the left-hand side, you'll see an ultrasound. This is what we can get in the emergency department. So at the top of the picture is the anterior abdominal wall. The bottom of the picture is the back of the patient, and you can see that there's a shadow from the spine. If you look at the arrows, you can see the size of the aneurysm. I think I measured this at about 7 centimeters. And on the left lower part of the aorta, you see an opening or a dark spot. That's the normal lumen, and all that gray shaded area within the aorta is clot. If you look at the middle picture, that's a cross-sectional CT, and you can see the one arrow shows you clot, and then the arrow at the bottom right, that's actually free-floating blood in the retroperitoneal space. So this is a ruptured aneurysm. And then on the right-hand side, that is actually what it looks like after they put a endovascular graft in, which is becoming, or has become, the most common way for surgeons to manage aneurysms. So how do we manage it? Well, we have to treat the patient in really two different fashions. If the patient's symptomatic, then we have to rapidly identify the problem. If the patient's hypotensive, we start resuscitation with blood products, and we get the surgeons involved early. We don't need to have an absolute final diagnosis before we start calling vascular surgery. They would much rather be in their car and get in to see the patient so they get them taken care of. If the patient has an acute abdominal aortic aneurysm that is symptomatic, meaning it's ruptured or is leaking, the only option is surgery, which can either be done with an open technique where they open up the abdominal wall and place in a graft, or they can go in through the groin and do an endovascular repair. The endovascular repair is more common, although studies at this point suggest there's no difference in outcome between the open and the endovascular procedures. Occasionally the patient is not a good candidate for surgery, and we treat them medically, and that tends to be the patients who we think they have really no chance of surviving the surgery based on chronic medical conditions or other reasons. If the patient is asymptomatic, we just happen to identify that they have an abdominal aortic aneurysm, we will refer them, or we will contact vascular surgery, talk to them about our findings, and they may or may not keep the patient in the hospital depending on how bad the aneurysm is. If it's a small aneurysm, they'll see the patient in the office, and they'll do imaging every 6 to 12 months to monitor the size of the aneurysm. And when it gets to a certain size, usually around 5.5 centimeters, then they'll talk about operative repair with the patient. In these patients, it typically is an endovascular repair. Another thing to talk about is acute mesenteric ischemia. This is really an issue where the gut does not get adequate blood supply. It can be chronic, where the patient has intermittent abdominal pain. We call that gut ischemia or gut angina, similar to a patient who has coronary artery disease and have episodes of pain when they exercise too much or do too much activity. Well, with the gut, if you make it work too hard by eating, you may develop symptoms of gut ischemia. If you look at the picture on the right, that purplish section of gut, that's ischemic gut. It's not getting adequate blood supply, and it probably is end up being resected. Most common cause of acute mesenteric ischemia is atherosclerosis, but about 50% of mesenteric ischemia is acute due to acute occlusion of the superior mesenteric artery, which is a big artery that comes off the aorta and supplies a good amount of blood to the gut. And acute mesenteric ischemia with embolism to the superior mesenteric artery has about a 50% mortality rate. So this is a bad disease. About 10% of the cases are due to venous causes, venous problems. It's kind of like having DVT of the gut, just like you might have DVT of the legs. Overall, acute ischemia has about a 60 to 80% mortality, and that in a large part is due to delay in diagnosis. This is not always an easy condition to identify. There are certain risk factors. Atrial fibrillation, cardiomyopathy, and cardiac valvular disease are risk factors. AFib is a big risk factor because you can have clots develop in the atria as they're fibrillating. A clot can break loose and be pushed out peripherally, and that can result in a stroke, or it can go to the gut and cause acute ischemia. Like I mentioned, atherosclerosis is a risk factor, as are hypercoagulable states, estrogen therapy, and patients who are hypotensive for some reason for a prolonged period of time. What are the symptoms? To me, the biggest symptom is pain out of proportion to abdominal exam. So if you have a patient who's writhing in pain and you look at their belly, you examine their belly, and it's really not that impressive, the first thing I think about is acute mesenteric ischemia, particularly if the patient's in atrial fibrillation and not anticoagulated. Typically, these patients will develop peritoneal signs late in the course of their illness, and what I mean by that is, where they have guarding or extreme sensitivity to palpation, or they have rebound. Again, these conditions have a high rate of mortality, mostly because of delay in diagnosis, which doesn't mean you're not getting good care. It just means it's difficult to diagnose this condition. How do we diagnose it? Well, high index of suspicion is important. Like I said, atrial fib patients with abdominal pain, or any patient with abdominal pain out of proportion to exam. Again, peritoneal findings are late, meaning extreme sensitivity to touch, extreme tenderness. Imaging, typically if we have a high suspicion of acute mesenteric ischemia, we go right to CT angiogram or CT of the abdomen with contrast. The other options are there, but we typically go right to CTA because it's quick and immediate. From a laboratory work perspective, it's really not very sensitive, not very specific. You might have an elevated white count. We can get a serum lactate on the patient, which, if it is elevated, is very suggestive of ischemia, but it's not specific. It doesn't say, yes, this patient has ischemic gut. It says this patient is very likely to have it. Some imaging again. If you look at this on the image on the left, this is an image of the patient, and if you see the red arrow, there's that gray column of contrast coming from above, and then it cuts off. Well, that's the clot. If you look at the image to the right, you can see the arrow, and you see kind of a round thing with some white around the periphery and a dark spot in the middle. Well, that's the superior mesenteric artery, and the dark spot is the clot sitting there that's causing the patient's ischemia. How do we treat these patients? Well, if the patient has an acute arterial clot, they go to the OR and they have surgery. The clot's taken out. Any non-viable gut is resected. If it's a venous problem where there's like DVT of the veins of the gut, we tend to anticoagulate those patients and reduce their risk factors. So if they're hypertensive, we treat hypertension. If they're diabetic, we get their blood sugar under better control, and so on. The last condition I want to talk about is acute arterial occlusion. I got this picture, and when you look at it, it's like, which is the abnormal body part? Well, actually, it's supposed to be the right leg. It's cold. It's pale appearing. So, what is acute arterial occlusion? It's an acute clot to an extremity. It usually involves the lower extremities, one or both, depending on where the clot ends up. And occasionally, though, it can go to an upper extremity. It really is the same kind of disease process as pulmonary emboli or ischemic strokes or mesenteric ischemia. Same etiology. So embolic events happen where there's clot that goes like from the heart out to the periphery is 30 to 40% of the time. Thrombotic, where there's a narrowing and that acutely becomes occluded, like in a myocardial infarction, is 50 to 60% of the time. Risk factors have to do with really history of previous peripheral vascular disease, atrial fibrillation, any abnormal cardiac valves that can form clots that can break loose, endocarditis, which is where we develop infected heart valves, can be a problem. Atherosclerosis of the vessels, of the arteries and the extremities are a risk factor. You can have narrowing and then of an artery, such as the femoral artery or the popliteal artery. You can then develop a clot that goes to it, and you can get into trouble. And then hypercoagulable states are also a problem in some patients where they just clot more easily. What are the symptoms? Well, we talk about the 5 Ps, and you don't have to have all 5, but these are things to think about in any patient with acute limb pain or symptoms, particularly if there's not associated trauma, particularly if you're talking about an older patient or a patient with risk factors. So the 5 Ps are pain, pallor, meaning the body part looks paler than the rest. Pulselessness, so if you have a patient with acute limb pain, check the pulses. That's an absolute. Paresthesias or numbness, so the patient can have a painful but numb extremity. Paralysis of that extremity, inadequate blood supply, the muscles don't work. Another way to assess for paralysis is not just can they move it, but do they have pain with movement? So if the patient's got a cold, pulseless foot, I ask them to move the foot and see if it causes pain with movement. And then poikilothermia, or coldness, lack of temperature. So those are the 5 Ps. They're always something to think about. The complications, well, you can lose the limb. If you have an acutely ischemic limb, particularly a lower leg, you can lose that limb or that lower leg if the clot is not removed, if blood supply is not restored. Even if it is restored, you can develop contractures because you've had muscle death due to delay in diagnosis or treatment, and you can develop skin necrosis just because there's inadequate blood supply, just like in patients with chronic limb ischemia can develop skin necrosis as well. Well, how do we make the diagnosis? Well, again, high index of suspicion, exam, looking for those 5 Ps. Imaging, we can do imaging with ultrasound, which is where they look at the waveforms in the arteries. If we have a really high level of suspicion, we may go right to CT angiogram or regular angiogram. The CT angiogram, again, is easy to get. It's readily available. Lab work, again, not very specific. We may see an elevated lactate. We may do a creatinine kinase, which is a test for muscle injury. It's the same test we do for rhabdomyolysis. That might be elevated, but again, by the time the CK is elevated, it's pretty late into the course of their illness. Here are a couple angiograms. On the left-hand side is a CT angiogram, and you can see on the, again, looking at this picture, your right is the patient's left leg, your left is the patient's right leg. The patient's left leg, there's a column of dye that acutely is cut off right at about the knee. That's consistent with acute clot. If you look at the CT on the right, you can see where the arteries to the right lower leg, the left lower leg, your right, the patient's left, with the red arrows, there's no dye to the left lower extremity, whereas if you look on the other side, it gives you a nice point of comparison. You can see that column of white dye that goes down to the ankle. So that's a good example. So how do we treat it? Early suspicion, early recognition, early anticoagulation. If I have an extremity that I think is acutely ischemic, I will anticoagulate them with intravenous heparin as one of my initial orders. I don't wait for imaging to come back. I can always stop the heparin. If the patient has to go to the OR, they can stop the heparin for the OR. Once you stop it, the heparin's effect of anticoagulation is gone in 10 minutes or less. So I start them on heparin. I keep them on heparin until I can verify they do not have an occlusion. And then I also get the vascular surgeons involved early. So if I have an acutely ischemic extremity, I will notify the surgeon that I've got the patient, I've got them start on anticoagulation, and they're going for imaging. Surgeons like to know about this early, not later in the game. So in summary, all the things I talked about are bad. I wouldn't wish on any of us or any of my enemies. You have a high level of suspicion about these problems. Examine the patient. So if the patient's having right-sided facial pain, they look for evidence of Horner syndrome, look for lid droop, look for a small pupil compared to the left. If the patient's got a acute pain in their lower extremity, take their pants and socks off, look at the foot, compare it to the other foot. Is it warm or is it cold? Does it have a pulse? Does it have sensation? Examine the patient. If you're worried about a patient with possible aortic dissection, get a blood pressure in both arms. Again, high level suspicion. And then also, when you give your radio report, when you talk to the staff or talk to the providers in the emergency department, pass off your concerns. Communicate. So it could be, hey, I'm bringing a patient in, they have acute right leg pain, the leg is cool, pale in appearance, it has no pedal pulses, I'm worried about a embolic event or limb ischemia. Those things are greatly appreciated. It's one of those things where if you think about it, you got to prove it's not there, and we much rather explain why it's not there than say, oh, you missed something. So, take a look at the patient and pass off your concerns. That's all I have. Next month will be the October Mech Minute. Hopefully it'll be about strokes and some changes in stroke care, but more to come. So thank you for listening.